Okay, so as I said, I'm going to go ahead and introduce our final speaker of the day. That will be Dr. Grant Garcia. Dr. Garcia is an orthopedic surgeon at Orthopedic Specialists of Seattle in Ballard. His primary focus for his practice is sports medicine, including shoulder, knee, and elbow surgery, as well as biological therapies. He has a great interest in returning athletes safely to their sport after shoulder, knee, and elbow injuries and surgeries. Dr. Garcia grew up here in Washington on Mercer Island. He went to medical school at the University of Pennsylvania School of Medicine. He did his residency at the Hospital for Special Surgery in New York City, as well as a mini shoulder fellowship in France. He completed a fellowship at Rush University for sports medicine and shoulders. He is also fellowship trained in orthobiologic treatments. Today, he's going to be speaking to us about adolescent orthopedic sports injuries. Please welcome Dr. Garcia. Should be on.
All right, good.
Here's your clicker.
All right.
Forward that.
Awesome. Thanks. All right. Hey, everyone. Sorry, last lecture of the day. We'll try to keep it interesting. It's sports, so it's fun. Not too many gory pictures, so we'll keep everybody's lunch down this time. All right, so now I had the task of talking about adolescent sports injuries, but the one thing I know people wanted to hear about was concussions, so we'll talk about that as well. All right? So clicking through. So first of all, introduction. Adolescents, they're a unique patient population. Many are involved in high-level sports, and there's this sort of growing interest in super specialization. If you talk to any of your patients or my patients, they come in, really everyone's starting to do one sport so they can be sort of the best athlete in that level. And as a result, injuries are becoming more prevalent. And then so today we're going to do an overview of the adolescent sports injuries, diagnosis, imaging, and treatment options. So what are the degrees of specialization, and so how do they categorize? So you have, I think that, 10 years ago, you'd have more in the low and the moderate. So you have to have one of those categories for low, year-round, single sport, or quit all sports. But what I'm seeing in my clinic and what I saw in my training was pretty much everyone was in a high specialization sport when they're past 8th grade. So they do more than 8 months per year of year-round training, single sport, and then they quit all their sports to focus on one sport. The one thing you see less of is there's a little screen up there, but the risk of acute injury is less because they're sort of conditioned. But the other issue is you see a lot of more serious overuse injuries. And in terms of a surgical standpoint, there's never really a good time for them to have if they have something wrong with their meniscus, et cetera, they're never really willing to take off any time to have that done. So it's always like, oh, when's fall baseball done? Well, actually, there's winter baseball. Okay, so winter baseball's done. So when's that? Okay, there's spring baseball. So there's never really a break. And then again, you've seen probably a lot of collegiate athletes or taking care of some older people, but it's not the same as an adolescent. For youth in general, they have less coordination, less body control. In adolescents, they have increased injury risk because they have growth arrest, and that makes this whole level of complication added to it. They're faster. They're faster than adolescents themselves. They're still developing motor skills. And again, they're more impulsive and emotional. And they also have this invincibility thing. So you tell them you actually have a cartilage defect, that's a problem there. It doesn't really matter to them because it doesn't hurt that much, or they're like, I'll push through it because every other ache and pain I did. And the biggest issue by far is parental expectations. That's always the hardest part in the office, and that's why most kids under 15 in my office take an extra 15 minutes just for the patient's parents themselves, because they always think they're all going to go pro, and you have to basically explain to them and try to find out what level they're at. So as a sports surgeon, the one thing I learned was how fast a fastball needs to be in order to be in the Division I athletics versus professional level, because as soon as you ask a pitcher how fast their fastball is, you can know immediately how good they are. Just an example. So it's good you have to know these things before you talk to them, because the parents are going to tell you 100% scholarship guaranteed, definitely going pro. Every patient, which is impossible. So biggest thing, overuse injuries. 15% of adolescent injuries affects the physis, tend to be more common during peak growth velocities. And this is again due to this repetitive overload and excessive remodeling of the physis itself. Okay, so high school sports injuries. Most commonly they're sprains, but as you can see, and this color's not showing up well here, the concussions increase with competition, and that's because people tend to, one, hide themselves when they get hurt, like a lot of the football players on Mercer Island team, and in general, when they get hurt, they don't want anybody to look at them. And if they get knocked out and they sort of feel like a little dizzy, they're trying to get back in. It's always never trying to see the doctor or the trainer. So this is a big one everyone wants to know about. I saved this for first so we can sort of be more clear and think about it and hear it. So traumatic, what's a concussion? It's traumatic injury to the brain, alters the mental status, and can occur without losing consciousness. This is really important. And 50% of all concussions go unnoticed. So, and it's really important that the parents are informed too, because a lot of times these kids will get a concussive symptoms. They're going to hide from the trainer, and they see me, they run. And they don't want anybody to look at them because they won't want to be taken out of the game. And so this is really uncommon, but it's just something you should know. There's something called second impact syndrome. So if they get a really bad concussion or head injury, second injury before that's healed, like for instance, they play another game in 2 or 3 days, that can be devastating to the point of fatal. But again, it's difficult to determine if the brain's healed from the first injury. In some, like in the professional sports, they'll do MRIs, et cetera, to try to look for bone contusions. It's just not possible in everyday use. So really you have to go off symptoms. And again, it makes a difference. So under 13, it's different. Adult recommendations can apply down to 13, but after that, you've got other different checklists which need to be used. And this is something called the CHILD. It's called SCAT-3 was developed. So it includes both parent and patient, as well as teacher and school input, and then also manages some neuropsychological testing that needs to be done as well. And you have to worry about school, because if it's an adult or it's a professional athlete, they don't have school. So those are some important things to think about. And again, you want to consider a pediatric neuropsychologist rather than just a standard neuropsychologist. So what are the signs and symptoms? We're not going to belabor all this. You can see it's a long list, but really it's sort of headache, feeling a little bit foggy, occasionally you have amnesia, irritability. These are much less common. Most of the time it's sort of, they feel a little headache. You kind of watch their eyes and see them kind of glossy. Those are some things that really, and again, for me, I don't take any risks. If I see anything is like that, they're out of the game. There's no point. Because they're never going to hide all these symptoms. They hide all these symptoms in every other injury too. So there's no reason they wouldn't hide their head injuries as well. And your most important thing is you take care of the player and make sure they're safe, not whether they win or lose the game. So on-field or sideline evaluation, when the player shows any features of concussion itself. So again, first aid, address the other injuries. So sometimes they may have a concussion, but they also have a leg injury. So you want to make sure you address, or they have a heart injury, or they have other issues that went on. You want to make sure those things are addressed first. Again, don't leave them alone. Make sure you monitor them serially. That's either you or addressing the parents or the other physician that you hand them off to. And then again, this is the most important thing. Any concussive symptoms, never allowed to go back in the game. So these are some assessments you can do. I honestly, techie guys now, you got to have it on your phone. So I have all these apps, so I don't even have to remember this stuff. I'm just like, I ask them like, do this, or this, and if anything hits red, which is yes or no questions, they're out. So, but basically, if you read this is a lot of stuff, but if you read this, if they lose on any of these points, they're out. So there's such a low threshold to pull them out of the game. And this is important. So again, it's initial rest. So there's one, everyone knows the physical one. No playing, no exercise, be aware of exertion activities. But people don't understand the other part, the cognitive rest. So these kids go home and they'll play video games, they'll be on the television. That's just as important as not actually going back into sport. And again, make sure they're not sleeping during the day. They could feel pretty somnolent. Usually 7 to 10 days. And then really what matters is the return to sport. So here's this big protocol. This is what almost every group does this in terms of professional athletes, college athletes, et cetera. And a lot of the trainers do most of this for us, which is nice because we're not seeing them every day. But they have this stepwise process. Each one of those you have to recover by a day. And then you can see here if any symptoms come back, they get booted back to the next level. So that's why even you see these guys in that, like the Seahawks, et cetera, they're not coming. Generally, it's hard to come back in a week to make this process because this has to be at least 7 days. All right, so that's concussions. So let's talk about some more, simpler things to talk about, shoulder injuries, et cetera. And again, I sort of simplified all this stuff, but I'm saving a little bit of time for questions of more orthopedic-related surgery stuff, but I want to make sure you got an overview of everything. So clavicle fractures, very simply, there's 3 main types of clavicle. Again, fallen outstretched shoulder, direct force onto the shoulder itself. A lot of times they present with you maybe some severe pain, they're guarding, difficult to carry the arm. You want to look for deformity. This is one big thing. A lot of times they miss is scapular fractures, so they'll get an x-ray just of the clavicle, and they'll be totally missing a scapular fracture. Most of the time those aren't operative, but it's good to know because if the patient gets better at the clavicle and they're still having pain, it turns out they actually fractured the scapula as well. Usually an x-ray is sufficient. You almost never need anything else. So this is one thing to remember. I put this up here because I actually missed it when I was in residency, and it's really important. So 5 to 10%, so this is in kids under 20 years old. So 5 to 10% of clavicle fractures, right here you can see they're actually not clavicle fractures. They're essentially AC joint injuries because they still have this tube intact, as you can see here. So they look like they're high riding, And if you take it to an orthopedic surgeon that doesn't really know what's going on, they may actually try to fix that. And that's a problem because it doesn't need surgery. It will actually remodel itself. As you can see here, that tube stays intact, and then it actually F is what it turns out to look like. So you don't want to fix them. So it's the last physes to close. So under 21, you see that type of injury, remember, let's at least look it up or talk about it with somebody else. Let's see, 1 second. Okay. So management, usually sling, rehab, range of motion. That's for the minimally displaced ones, sort of less than 2 centimeters displaced. Now, the literature is showing to be more aggressive. I've gotten more aggressive on fixing these. Patients tend to be able to get back. They get back about double the speed that they would normally, and it's kind of a discussion you have to have with the patient. But any tenting, displacement greater than 2 centimeters, pain, persistent pain after healing. So there's a 5% non-union rate. Most of the time, the non-unions don't hurt, but if they do hurt, then you have to obviously go in there and fix them. But it's a much different procedure. So the thought process is, and the Canadian data is showing now that sort of being more aggressive on these clavicles, there's a 5 to 10% decrease in endurance and strength. While they don't have any difference in range of motion, they feel strong, that shoulder is just not the same as the other one. And then anytime there's a combination, and that scapula, this is a little different. It's got to be like a pretty large scapular fracture to be considered a floating shoulder. All right, so that's clavicles. So AC joint sprain. So some patient may say, I heard I separated my shoulder a long time ago or something. Again, a blow to the top of the shoulder, fall laterally on it. So you have pain at the top of the shoulder, basically right around where the AC joint is, swelling, tenderness. And this is hard because a lot of times it's just this tear right here at the AC joints, not the CC ligaments. And so they may have no other symptoms other than pain and this positive cross-body abduction testing. So there's 6 types, and really you don't need to memorize all these. But biggest thing you need to know is that as long as it's not up too high, it doesn't need surgery. So 1, 2, and 3 don't need surgery. There's been a bunch of studies. I was actually involved in a few of them for the type 3 on asking for professional baseball players. And the biggest thing to know is that most of the trainers, even for type 3s, are not fixing them. Because again, the results are similar without fixing them and fixing them. Notoriously, these are really difficult surgeries, no matter how good you are above that. So it's something you really have to think about. It's not as much a complication rate like they have like a nerve injury, but that they actually will reoccur just because notoriously it's hard to keep that part down. But the 5s, the 4s, I'll mention the 4 one to you guys because you see how that on the x-ray looks like it's pretty simple. But if you get an axillary view, it's actually posterior, it's behind. And so if you don't get and a lot of people don't get axillary views. I do on every patient. But if you don't have an axillary view, you're going to miss that one. So don't forget that one. That one definitely needs surgery. And then type 5 is pretty easy. No one misses that. And then if you see a 6, just call right away because I've never seen one. So what do you do? So very simple. These are very basic. You know, again, the old theory was like every shoulder injury, let's put them in a sling and like have them do nothing for like 6 weeks. I'm pretty aggressive in terms of moving them because honestly, these things heal. And the last thing you want is a stiff shoulder. So grade 1, 2, or grade 1, 2 to 3 days, grade 2, roughly 1 to 2 weeks. If they're an athlete, and they have a grade 1 or grade 2, sometimes you can do an injection to get them back. And I just do that sort of for playoff situations. And because they're not going to do any more damage by injuring it again. But again, it hurts, so that's the best way to get them back. But usually that's very uncommon. I just put that star there. Ice and then rehab. Grade 3, I mentioned before, controversial. Almost always it's really rest and try it out because the data shows that if you fix a grade 3 within 5 weeks, it is exactly the same as if you fix it at 10 weeks. So why not try non-op and see how they do and then come back and take care of it. And then 4 through 6 we mentioned before was surgical reconstruction. Okay, shoulder dislocation. So usually traumatic, shoulders abduction, forcefully external rotated. This is for anterior shoulder dislocation, but most of the ones you'll see are going to be anterior. And then fall into an outstretched arm, usually discomfort, and they usually have a generalized weakness, and you're freaking out like, oh my God, did they have a nerve injury, et cetera. And they can, but usually it's just that sort of a dead shoulder feeling, and that comes back with therapy. So pretty simple, pretty easy to find. Be careful of the posterior dislocation. I just had a guy I did a surgery on with a blocked posterior one. They didn't miss it, but you can miss them when they're posterior. We're not going to talk about that too much, but just bringing that up. Crepitus, and again, get a neuro evaluation. Now, we're just talking about adolescents. So under 40, axillary nerve is the most commonly damaged. Again, just when you put it back, hopefully it comes back. Most of the time it does. And occasionally you have to do some other stuff as well. Over 40, rotator cuff tear. Seen that a ton of times. So people come back, they don't even know. They're like, oh, I relocated my shoulder. I've been having weakness for like 6 weeks, massive rotator cuff tear. So that's pretty common for over 40. Again, you usually just need x-rays. Now the trick here, we'll talk about in a second, but basically there's tons of different reduction methods. There's like the Hippocratic one. There's one where like 3 people are pulling on the leg like this and trying to pull the arm in. There's one where you just hold it over the bed and let it pop in. There's all different type of methods, and all of them work well. I've tried a bunch of them, and there's no issues in general. The thing you want to be careful for is that you have relaxation. You don't do any more damage to them, and you don't miss anything. The one thing you can miss is if there's a fracture of the head, and this doesn't happen in adolescents as much. I've heard of people in the ER trying to reduce it and breaking off the head because they didn't see that. Yeah, it's not good. It doesn't usually happen in like 13-year-olds, but we're just talking in general too. This is important though. Short period of sling. Get them moving. They're going to get really stiff. Okay, that's more important. If you see any of these things, so fracture of the glenoid or the humerus, refer them to us. Bankart lesion, that's harder to see because you're not going to see that as much. There's a bony Bankart, but the other one's a labrum, so you're not going to see it on the X-ray itself. And then if they have persistent pain or instability, you know, don't be afraid to send them to us to have evaluation. So biggest thing is you don't have to know all these views, but understand that you don't want to miss a little chip fracture. And I can't see this one. That's of course it's being blocked by the screen up there. But there's different views you can get here to look at the humerus and the glenoid. And the biggest thing here is sometimes when they dislocate, even the first time, these young guys or gals, they're so aggressively dislocating, they make a bump in the back called the Hill-Sachs lesion. And as you can see here, that's pretty large. They usually get larger than that. But as they go back into that, they're catapulting themselves out. So that increases their risk of recurrence like 70%. And if they knock off a piece of the glenoid, that needs to be fixed pretty promptly. My third case in practice was a huge piece of the glenoid knocked off with a rotator cuff tear. So, you know, they happen and you see them. Again, you want to assess for fracture there. You want to assess for, again, recurrent dislocations and anything else that might be hiding. If you have any concerns, don't feel embarrassed about getting an MRI. Just get it. It's more information. You have that information. But this is the most important slide I'm going to tell you about shoulder stuff. Understanding that there is extremely high chance of it happening again if they're under 20 years old. Almost 100% you can see there. So greater than less than 20, almost 100%. As soon as they hit the 20 mark, it drops a lot. So shoulder instability is notoriously, I really like this topic, but in general, it's notoriously a difficult situation to deal with because you're telling a guy that all the times they come to you're like, oh, you're fine, therapy, 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 therapy. And you're like, well, listen, it's your first dislocation. You're a football player. We might want to think about fixing this. And I usually give them until the second one just because it's pretty aggressive to go after that. But then you understand that it's a 92% chance. Risk factors are age, gender, and athletic involvement. There's some new studies that show with contact athletes that you want to be even more aggressive and not just do a scope, but you do something called a ladder J, which is a big open procedure, and you put a piece of bone there. Because the more dislocations they have, the higher risk of arthritis later. Again, you want this persistent sensation of shoulder subluxation or dislocation in non-traumatic situations. So as soon as your patient comes to you and says, you know what, I dislocated my sleep, send them, because that's not good. I just saw a patient that's dislocated my highest I've ever seen is 150 times of dislocating. But by that time, there's a real problem, and you definitely need a much larger procedure. I don't know how they got to that, but. So there's some interesting exam findings. We're not going to go through them for the sake of time, but there's these different type of tests in terms of anterior. I'll be honest with you, I've done these a lot. They're still hard to do in a patient that's awake. I always do them right before a surgical procedure to confirm everything, but these can be ways of finding things. Just remember, though, some of these patients have both anterior and posterior instability. So I've seen a surgeon that fixed anterior instability and completely missed the labrum in the back was torn. So the patient was popping out the back after the surgery because they tightened him so much in the front. But you always want to make sure you get an MRI, and a CT scan is really important. This is a big thing that's relatively new over the last 5-10 years. And we usually get 3D reconstructions because that glenoid is so important. It used to show that like that golf tee, when it's 20% off, that's pretty large. It's hard to miss. But the newer studies that actually we just did at Rush show that it's only about 10-12% actually means you start need to think about reconstructing the bone. So this is a really complex problem. So usually rehab, anything farther than that, we repair the labrum through the scope. But again, it gets the more fun stuff. A lot of French words here. You can see ladder J, remplissage. But anyhow, these are the two big procedures you do to address each of those things I talked about. So Hill-Sachs lesion, remplissage, that's through the scope. Ladder J, that's open procedure. There's occasionally cases you can do it through the scope. And there's still indications to do some bigger open procedures as well. That'll be the longest talk for the shoulder stuff. But All right, this one's important. I just had a patient today. You get these patients, generalized ligamentous laxity. They talk about their swimmers, or they're like, you know, my shoulder keeps popping around. It never really feels the same. That's totally different than a guy that's a football player that popped his shoulder out the first time. They generally have hundreds of micro insubluxations. A lot of times they don't even know what it is until they see you. They're the ones that can like bend their thumb and touch their feet. They touch their toes all the way with flat palms. You know those people you've probably seen with high ligamentous laxity. These are notoriously difficult to treat because one, first of all, rehab is generally the thing I do. I avoid surgery as long as possible on these type of patients because it's high recurrence rates. Like if you fix them and you don't do a really good job, it could be up to 40% recurrence because you have to fix the entire capsule. It's not a labrum issue. Usually, what's interesting is their joint looks perfect. They've dislocated or partially dislocated about 100 times, and they have no issues because it comes out so easily that it goes right over the bumper, just comes right back every time. So it's something that's interesting. You need to know that. So they're not all the same. So if someone says they have shoulder instability, this is a totally different type of instability than the one you saw before. So impingement, you see this a lot. Basically, there's multiple ways you can get to impingement, but basically the rotator cuff tendon abuts on the top of the acromion, and there's usually a little hook there, type 2 acromion, that causes pain there, and usually they complain of lateral shoulder pain. The one thing I always mention to patients that people don't realize is you might have patients that say they have elbow pain, they go like this. Well, the bursa goes almost all the way down to here. So they'll actually complain of that pain down there, or really it's coming from the shoulder itself. So biggest thing you do is this sort of testing here, and that's good. But I'm pretty aggressive with injections, except in younger kids. But the cortisone injection is really good for diagnostic purposes for the subacromial space. One, I don't do it as a treatment. I try sometimes. I'm like, listen, this should help you. But really it helps you information as to what's going on as well. Now, if a patient comes in, he's never tried anything else, I would just go straight for the rest, activity modification, and cuff strengthening, especially under 13. But in my little bit older patients, I always try to go with the injection because it gives me more information. Because if it gets completely better, then I'm like, okay, I pretty much know what's going on. And I do that even before an MRI. This is really important. Almost never surgical for a younger patient. They almost always get better. Even a really bad injury, they'll be like, my buddy's was lifting, felt some strain in his rotator cuff, thought he tore his cuff. Anybody under 30, usually it's not a cuff tear. It's usually this, impingement or sort of cuff tendonitis. And almost always it's just a shot and they can get better. So it's almost never surgical. So this one's interesting, Little League shoulder, so proximal humeral epiphysitis. So it's a Salter-Harris 1 injury occurs in these throwers, 11 to 16. Again, repeated throwing, worse with throwing, insidious pain, it hurts at the area, and you have a loss of motion. Sorry, this x-ray is not projected, but you guys can see the Physeal difference. That's really bad. This is like only internet pictures. So that's what it looks like when it's bad. Usually it's just you have a lot of these kid things are a heightened suspicion for something going on. So the guy's like, I'm on the select team. Again, I play winter, spring, summer, fall, and every break in between baseball. And you got to start thinking about these things. So again, biggest thing is, it's like concussions, stop throwing. You need to stop. And that's the hardest part. This is why my office visits with these patients take so long. I'm trying to convince them to stop doing it. Return to play gradual, and again, they need to focus on other things. Some of these kids, all they want to throw is a fastball 93 miles an hour. That's all they care about. They don't care about any rest of the body. And so they have these terrible throwing habits, and they get this type of injuries and others. So this is important. This is from the Andrews Institute. James Andrews is like the guy that does every Tommy John in the world. So he basically came up with this pitch count with some of his colleagues. So if they're under 10, no more than 75 a day, et cetera. And these are really good to follow, and this is what a lot of the college, high school coaches follow. So this one happens a lot with the football players, but they get this burner, traction injury right here on the brachial plexus, usually immediate pain down the arm, numbness, weakness. Everyone freaks out. So the biggest thing to know is that if it's unilateral, first time, it's okay. A lot of times even they can go back to play that day. If you start seeing bilateral and you start panicking a little bit, because you're thinking about the cervical spine rather than a traction injury right here. So I always make sure I do a good neuro exam. I let them go back to play occasionally, and then rest and observation. But a second time, I'm going to get an MRI. So I had a player that had that, and then a second time, I was like, you're done. Get the MRI to rule out any other issues, because they can get things in their cervical spine that can be missed. So this is really the great part about orthopedics. Everyone always jokes, but this is like the way I think about it. I'm like, person comes in, they're like, tell me where it hurts. All right, I know what it is. You almost, like, it's literally like that almost all the time. If you ask them to point, you know, you have the patient that's like, oh, where does it hurt? And they go like that. You guys know what I'm talking about. Those are always going to be fun. But a lot of times they can point to certain areas that are injured. So ACL tears, everybody likes this one. Most injured ligament in the knee. Female athletes in general are at higher risk, so 2 to 8 times. I always tell patients, I almost know it's an ACL because they come in, female soccer player, 20 years old, blown up knee. So the studies show that if they have a blown up knee and they're under 22 and they play soccer, it's a 70% chance of ACL. So you almost can guess it and you'd be right. And a lot of times you can't get a good exam on these patients that come in with an acute ACL. So I usually send them straight for MRI because it just hurts them more to try it. You have about 4 hours after the injury to really diagnose it. And then after that, you got to wait a couple of days till therapy, et cetera, kicks in. So they feel this pop, unstable giving out, and those are more chronic situations. And they have these positive exam findings. The pivot's really difficult. You probably won't be able to do it, and no patient's going to like you after, and they're probably not going to come back. So I don't ever do that in the acute setting other than if they're asleep. I always pivot them before I do the ACL surgery because that's really the reason they're getting their surgery done is to prevent that pivoting from happening. So X-ray, always get X-rays, and this is really important for under 15. You want to assess the growth plates, rule out other fractures, because these kids can get these avulsions, these tibial eminence, and this is an easy surgery. You go in there, you put a screw or sutures and pop that down, and they'll do just fine. They don't need a reconstruction of the ACL. Now you wait 6 months on this, that's bad. And also you want to assess for cartilage and meniscus status. So a lot of these kids, these are young kids, they have a really, really big injury to get that ACL to tear, and they can have cartilage injuries and other meniscus injuries. And then we like to repair those things or take a small piece of cartilage out to save their knee. So a lot of guys, there's some places on the ski slopes that tell you need to do your surgery within a day, and that's so the patient doesn't leave the actual facility, but the studies show you should wait 3 to 4 weeks because they get stiff. They get something called arthrofibrosis if you do it soon. So that's important to understand. Surgical reconstruction, there's tons of different graft types. We don't have time to talk about it. We could do an entire talk just on ACL. But again, why do we care about the physis? So if you don't do the appropriate physis surgery, you can get things like limb length discrepancy, femoral overgrowth, or valgus deformity, things like this. It's not that common because most surgeons now are fellowship trained and understand this physis part's important, but it's important to really look at it and think about it because I do different ACL surgery for a 14-year-old boy that still has open physis versus a 16-year-old boy. All right, so the most common meniscus tears you're going to see under 15, they're almost always discoid meniscus, and usually lateral side. And a lot of times they'll be like, well, how did I get this, doc? I don't know. And you'll say, you probably were born with it, and then eventually it tore. So a lot of times they're asymptomatic, and on MRI they look like these big sausages. So the examples are 3 slices of the MRI show a meniscus that looks like this is almost always a discoid. And you want to make sure it's similar to any meniscal findings. MRI usually rules it out. If they're asymptomatic, let's say you get an MRI of a patient and they have this, but they have no symptoms, you don't do anything with them. But if they tear it, the plan is that a lot of times you go in and you want to take that small piece out. We call it saucerization and try to recreate the natural tendency. So some non-operative things, there's Oscar Schlatter. So again, that's an injury to the growth plate, and we've probably all seen this. 20 to 30% bilateral, so remember to check the other side as well. And really, it's very uncommon to do surgery for this. But focus on reducing pain. Again, limit participation until it's pain-free, and formal therapy, so focusing on the quads and the hamstrings. And you may not have heard about this one, but maybe. Sliding Larsen-Johnson syndrome, essentially the opposite area of the patella tendon on the distal pole. And again, superior attachment patella tendon, it's again from tightness of the surrounding muscles. And then again, bottom of patella is worse with pain and bony irregularities you can see on on X-ray. And then it's therapy and patellar strap. So here are the X-ray findings. You can see I always see those a lot in like 30-year-olds will come in and I'm like, did you ever have pain in the front of your knee? They're like, yeah. So at least you like feel smart that you could diagnose something on them. But you know, you see that's pretty evidence of a physeal injury of Oscar Schlatters. And then you have the sliding Larsens, which is more on the patella. This is a lot less common. I'd say you see this about 10 times more than you see this. So patella dislocations. Sorry, it's gory. I promise not. But, these are important. I have seen 4 in the last month that came in, and they actually were reduced, and they didn't even know it. They thought it was their ACL. So a lot of patients say, oh, I tore my ACL. Can you fix it? I'm like, well, let's get MRI and figure out what's going on. And most of the time, actually, a lot of times it's the patella. So dislocates laterally. Again, it tears this MPFL ligament, significant deformity. If you ever have one of these, it's actually pretty simple to put it back in. They're not going to like you, but you just sort of make them take a deep breath, extend their leg, and pop it back over, and they'll pop right back. They're very satisfying. But the biggest thing to remember, and this is the part that I cannot emphasize enough, I have seen 4 of these, and 2 of them I needed surgery for this. And they went to my office and they got surgery the next week. Make sure you get an MRI if you're concerned about something, or really, I just do it for everyone. Make sure they didn't knock a piece of the cartilage off. So when they dislocate, the only reason to do a surgery on a first-time dislocator is if they knock a piece of cartilage off. So I've had 2 so far out of the 4 I saw that did this. I do not fix the MPFL. I just take off the piece of cartilage, let loose piece, clean it up, and watch it. Give them some therapy, because usually a first-time dislocator, because it's pretty aggressive. But if they have multiple dislocations, I have no problem with doing a ligament reconstruction of the knee itself. There's an MPFL, and there's some more complications. Sometimes they have malrotated legs, so I'll do like a bony osteotomy where you realign it. But again, this is a complicated issue. And then you have to talk about the cartilage, and we don't have time for that right now. So OCDs, I have seen one of these already in practice. These are always interesting because, you know, the kid's mom actually probably had it, or dad had it, and they were like, oh yeah, well I got mine taken out and now I have a total knee. So like that's not what you want. So again, there's likely a hereditary component. Usually in adults, it's more vascular related. This is important. Okay, it can be bilateral. So anybody comes in my office that has this, I always get an X-ray on the other side. I don't often see it, and that's because it's mostly found in MRI. This is an extreme example, but you want to be careful because you don't want to miss it. So I always tell the patients, so I have this guy, I have 2 OCDs I've seen. I told them, as soon as your other knee starts hurting, if it hurts, and their X-rays are negative, you got to come to my office and we're going to immediately get an MRI. Just to make sure we're not missing an OCD lesion, because I can save this if it's not broken off by fixing it. So it's insinuous pain, mechanical symptoms. The problem is usually they come in to see you when it gets stuck. And that means the bone's completely been lopped off and it's floating around in their joint. So that's too far gone to fix. So I just take it out. You leave the piece, you watch it, and see if they need something cartilage, like cartilage transplant later. And if it's not, but if they come in with pain, you get an MRI, you're like, oh, whoa. And you see this piece that looks just like that on MRI. And a lot of times it will have no signal under it. That means it's just a stable OCD, and that's good. But when there's fluid behind the fragment, that's really bad. That means it's about to break off. That needs to get surgery. Without the fluid, conservative management, restrict the weight bearing, wait 3 to 6 months. In these adolescents, there's a high chance of healing if their growth plates are open, so that's really good. So I tell them that there's a really good chance you're not going to need anything surgical. And then age is, again, most important factor. But if unstable, you fix it. So I go in there with the scope, 2 wires, cannulated screws, and then unfortunately, after 8 weeks, you're putting metal screws in, you have to go back and take them out. And if it's a loose piece, you debride, and that's it. No microfracture, nothing. You just watch it, see how they do, and if they do well, which a lot of them do, you do nothing. But if they don't do well, then you talk about a cartilage transplant, which has a much higher performance rate than microfracture. But we're diverging off cartilage stuff. So stress fracture, you've probably seen these before. There can be stress fractures anywhere. The most common one, you worry about tibia and the hip, but pain on exertion. Tenderness, I think this is a really good exam finding. One of my, actually, tumor doctor taught me this, and I don't know why he knew about it, but percussion at the tibia. If that hurts, really concerned about a stress fracture. It works really well, actually, for a test. And then you want to rule out any fracture completion with the MRI. You may not see anything on the X-ray, but if you have a heightened suspicion, stop sports, stop running, MRI. Usually it goes away after 4 to 6 weeks. I had a lady that came and saw me from a PT, called me, and they said they might have a hip stress fracture. She came in and she didn't think that she had one, and I got an MRI. It was 10% fractured, so that was a good call. This is just this weekend. So we put her on toe touch weight bearing for 4 weeks, and then non-weight bearing before that for 2 weeks. So she should do fine. But again, you miss it, hip fracture, in a 30-year-old. That's not good. Little leaguer's elbow, again, same type of thing as little leaguer's shoulder. Apophysitis commonly occurs in throwers, valgus overload. And again, it's basically the biggest issue is understanding that this patient needs to have a decrease in pitching. And again, here's the pitch count again to go over that. Rest, 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 rest is the most important thing, and they always forget all the other things. So it's important. That's your guys' job to show them that. We won't go too much into this. You guys can ask questions, but these are avulsion injuries, and these are all different places they can come off of, and these are the different things that can happen as a result. Again, exam findings, if it's less than 2 centimeters displaced, you want to refer it to us for orthopedics, but really uncommon to do surgery on these. Like to let them heal. You'd be surprised what the young patient's bone and cartilage and joints will do, and they recover really well without anything. Don't miss these either. I keep saying that, but these are all the ones. I always put the ones that anybody could miss, anybody who even knows what they're doing. So this is not something that's a really bad thing if you miss it per se, but again, I want to make sure you notice it. So I always check any of my football players that get ankle injuries. I'm always palpating any pain on the lateral side. I always ask their age because an 18-year-old still may actually have open physes, so it's an X-ray is always good. And it's one single X-ray if they're really worried about radiation. But the physis is the weak link. They usually don't get, they get ankle sprains, and the older guys get ankle sprains, but a lot of times the physis is the first to go, not the ankle ligaments. So you can get this ankle, you basically have an ankle fracture, and you're telling them to sort of walk it off and put a little wrap on it. So weight-bearing X-rays are good. A lot of times, this is uncommon that a person will be able to walk and give you this view, this shifted physis, but usually it's just at the distal fibula right here. And honestly, you don't know. You won't know. The only time you'll know is if you put them in a walking boot or something for a week and a half, and then you see some cortical bone growing there, and then you know it was a Physeal injury. So the biggest thing to do is just always be a little bit more cautious. Now, if it's a football player, he's able to not really tender after 2 or 3 days there, then I'd say probably not the injury itself. But if they're continuing to have tenderness at that physis, you should take it pretty seriously. It's a very simple treatment. It's a walking boot or a walking cast as tolerated, crutches if they have a lot of pain, and then you repeat the exam in 3 to 4 weeks. And again, I mentioned you can have some callus formation if it's 10 to 14 days. So we're almost done. Last one. So Seaver's disease, calcaneopophysitis, occurs at the growth spurt during adolescence. It's actually really common. My partner's kids have had this already, talking to them, but these are different areas that are increased risk for children to have them, and that calcaneus grows fast in surrounding muscles and tendons. And again, the growth plate's the weakest part, not the tendon, not the bone in children. So you have palpation, a lateral medial aspect calcaneus. Squeeze test is positive in these patients. They usually have tight calves and flat feet. And again, it's a clinical diagnosis. Sometimes, like the other one we showed you, it can have open physes. It can be a little bit irregular. This is very simple treatment: rest, ice, proper stretching, supports, heel cups, etc. And that's it.